Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. Your healthcare information is vitally important, but your physicians don't always have it right at their fingertips when they need it. We all know that feeling of repeating our history and our medications every time we see a new provider. There's a form, and then there's another form, and then there's another form. And is there a better way? That's the question. Collaboration and technology in our community are advancing so that your providers can have all of your information together in one central place. Tonight we're going to talk about how healthcare information is being shared in our community and how it can help you. As you know, this is a live show, so stay with us and think of some questions of your own you'd like to ask us this evening. The telephone number is 881-0013. We are also streaming live on Facebook, so if you're a Facebook person and don't always have a telephone in front of you, you're welcome to ask your questions live on Facebook. This evening's program is underwritten by FIX, which stands for Paso Norte Health Information Exchange. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing students for us. Today we have Heather Jones and Nicholas Martinez, and they're the ones that are going to be answering your questions on the line. They're going to be taking questions, actually, and then the doctors are going to be answering your questions. And we also want to thank the El Paso County Medical Society. We have some board members here this evening for sponsoring this show for over 22 years, and it comes to you once a month for sure, sometimes 2 or 3 times a month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Thank you again for joining us. This is a program that we had on a couple of years ago when FIX was just starting into spreading around El Paso, and I think that we've gotten so much better right now. If I go to the doctor or go to the emergency room, there's a lot of information about me that the doctors can access if for some reason I'm not conscious or if I don't have somebody with me. So that's one of the scenarios that we're going to be talking about tonight. Tonight's show is called Improving Patient Care Through Data Sharing. And with us this evening, we have Dr. Diego de la Mora, who is with Texas Tech. He is an internal medicine specialty, and he's the acting chief of informatics. He's the acting chief informatics officer, right? Informatics officer. So that's a new word for me. Thank you so much for being here. We also have Juan Escobar, who's been here before. He's a cardiologist. He's with Providence Medical Partners, and he is representing also the El Paso County Medical Society Board. So thank you so much for being here. And then we also have Joel Hendricks, MD, who today is a 4th-time grandfather. Sir, congratulations. He's not 900 years old, but we were joking about that before and I said I'm 902, so it's okay. But Dr. Hendricks is with the United University Medical Center, and he's the chief medical officer there. He is a former OBGYN, and again, new granddad. And then we have Emily Hartman, who I met years ago, and then we were in a cohort together about a year and a half ago, and she had a brand new baby. And now she has another brand new baby that's only 2 months old. Mm-hmm. So congratulations on that.
Thank you.
Emily Hartman is the executive director of, again, the Paso Norte Health Information Exchange. And for the evening, we're going to call it FIX, which we do PHIX, but we'll refer it to that a couple times throughout the evening. Dr. De La Mora, so I said what your title is, but what does that mean? We were talking about informatics officer. So let's start with that, because there's going to be people in the audience that are like, well, why do I share my information? Is it really good? Because it's the day and age where, even though it was 1984, Big Brother, that's still something that people have in the back of their minds. So what we want to do today is kind of debunk some of those myths. So as the from Texas Tech internal medicine guy, but again, the chief informatics officer, what does that mean?
Well, there's 2 questions to that. First of all, thank you very much for inviting me to the program. The Chief Medical Informatics Officer is a physician, generally a physician that works to, serves as a liaison between the informatics and the technology team, as well as the physician team and the clinical care team, to try to bridge the gap between those two and really move forward with the best technology for patient care. My job is to really find the best way to communicate the strategy and of the organization, and make sure that our information technology team is able to implement some of these new technologies that are coming out to better the patient's health.
And that's beautifully said. And Dr. Escobar, I'm going to bring it to you for a moment because, again, as a board member of the El Paso County Medical Society, there is a group of physicians all around El Paso, all around the county. And when we're talking with Dr. De La Mora about the technology that's being put into place, and I guess it's being updated a little bit every year, what difference has that made so far when it comes to your hat that you wear with the El Paso County Medical Society?
So I've been using the program we have in place for about a couple of years. I started in the beginning, since I'm on the board of the FIX. And what I found was that I was able to use it in finding patients information who had gone to other hospitals, other facilities that I don't go to. So for example, I would see a patient in the office who had been to University Medical Center, and I'm not privileged to have patients or care there, so I don't have access to the information there. And I could get into the information exchange and get information from that hospital, labs, x-rays, procedures that were done. All that information is available to me on the exchange, where it wouldn't be available to me otherwise because I don't have access to the hospital records.
Right.
So I think that it helps physicians to provide a better care because you have information. You don't have to try to get that information later, or you don't have to try to get it from the patient. The patient may not know what they had because they were sick and they just don't have all the information. And you may ask them, they say, you know, I had a lot of tests, I don't know, but if you go on the information exchange, you can get access to those records. And that's available for the hospitals participating, which include University Medical Center or Sierra Medical Center, Providence, all the hospitals of Providence, the Beaumont Hospital, and the VA.
Okay. And so the majority, but there's still a couple that need to get on board.
Yes.
And we don't have to name them, but I respect where you're coming from completely. Dr. Hendricks, with that smile on your face, like, yeah, let's get these people on board. As the University Medical Center, again, the Chief Medical Officer, you were talking a little bit before the show, because I was asking, okay, what questions should go to which doctor? So strategy. You're talking strategy in general, and it has a little bit to do with what Dr. Escobar was saying, but in your all-day, everyday job that you have now, explain to the audience why strategy in this particular situation is so important.
As we move to computers, unfortunately our computers don't all talk to each other. So tests are very expensive, and people can have admissions to the hospitals, and when they come out, they don't have that information. Trying to do it the old way of asking for the medical records would take a long time. So because these computers don't all talk to each other, then we're able to use the system to get that information, as he said, which is excellent for patient care. For our strategy, we have outlying clinics, we have the hospital, and those providers who are able to acquire this information get it quickly. So that, for example, if they come from our hospital to our clinic or to another doctor's office, they would be able to look that patient up, find out what tests they had, what was the last lab work, and what their discharge diagnoses were. And that's vital, and it helps him tremendously to be able to, what am I going to do today with you?
Right.
What am I going to do forward? How do we make a plan that'll help you stay out of that hospital? And as he said, I think aptly, that he doesn't have to be a member of UMC or any of the other hospitals. It's available.
Right.
We have the Department of Defense on there, so anybody in the military all over the country can have access to those records.
And that's so key. And I know as a cardiologist, Dr. Escobar, we talk often when we have a cardiology program about that window of time. Right? There's a window of time that if you know what's happening, if you get treatment, and if you have information at your fingertips, that window of time then is able to expand as far as the health and hopefully the saving of an individual. And I'm thinking right now just purely emergency room, but then going forward into everything else. And Emily, that's where I'm going to bring you in. So again, I remember when this was just, my goodness, 7-8 years ago, it was just something that we were thinking about. We, meaning the collective people that are in healthcare in general. Talk us through, if you don't mind, a little bit of when the genesis was into becoming what it is now, so that the people at home can kind of understand, number one, why this was needed and or a desire to do so. Because in the old days, you would have to sign form, and then there was about a decade ago when the doctors would be frustrated. It's like, I got to get this on the computer, and they're not technicians or IT folks, but now we're at a point where it's all there and it's beautiful. So there has been kind of a painful yet, what is it, that short-term pain for long-term gain. So talk a little bit about that and how the genesis is and to where we are now, and then also what you see in the future.
Sure, absolutely. So the organization was founded in 2011 to solve the fundamental problem that you outlined so nicely, which is my grandma at the doctor's office with her bag full of medications and her little notebook full of what the last doctor said, and trying to quarterback her own care in some ways, because it's so hard to get records back and forth across different facilities. So it started with that idea and that problem. In 2016, we started actively exchanging data. In the meantime, it was a lot of setting up legal agreements and technical infrastructure. And then in 2016, the Hospitals of Providence was the first to start contributing data. And since then, we've added a number of other partners, which Dr. Escobar mentioned several of: University Medical Center, El Paso Children's, Texas Tech, Emergence Health Network, 3 federally qualified health centers, Project Vita, Centro San Vicente, La Fe, the Veterans Administration, Department of Defense, and then we're just starting to move into private physician practices as well. So we have several that we're working with to bring them on board as well to keep growing and expanding our network.
And so on that note, is that part of your charge and your staff of trying to, create meetings and not talk doctors into it, but the idea of, okay, well, this is what the benefits are, and it would be great for you to join. And I know that's one of the questions here, but I figure since we're on that, how easy is it for a medical facility and or a private practice doc to integrate into this system?
Sure, so our team does the work, really. So we talk with an office about what their electronic health record system is that they're using. Our team comes in and finds the easiest way to get data from their system into the HIE, and then trains all of their staff on how to use it. So we do one-on-one training, sit down with folks, show them how to use it, look up their patients, and make sure that they know how to navigate everything.
Okay, nicely said. And now for the informatics officer, on that note, so talk again about, so taking what Emily was saying about training doctors and training staff, I guess it's more about training the staff. Are there some questions that you run into a lot, like some of the things that, if there is a resistance, what is it that you hear? And on the opposite note of that, what is it that you hear and how do you counter some of those questions?
I think some of the questions are related to how to access the information from the physician standpoint. I think overall it's relatively easy for the physician, yet at the same time it's very secure. We make sure that they follow and they have the right credentials and that they have access to our organization's records as well. That being said, we make sure that they have proper username and password, and we give them some training on as well on how to use the system. It's very simple, really. It's almost for them, it will be almost like accessing a web page in the internet, and then it just becomes a matter of looking for the patient. The information exchange makes it very easy for physicians because it allows, it pairs the physician with the patient. So if you have seen the patient before, it essentially limits that search to the patients that you've seen before. So once again, it's also very secure for patient to maintain confidentiality.
And extending into that, Dr. Escobar, I'm going to ask you again with whatever hat you want to wear, because again, several years ago, HIPAA came into play. So let's talk about the idea that HIPAA is still very much in play, and people who may have a thought of, oh my gosh, my information's just going to be out there. Well, HIPAA, again, is in play. Would you explain to the audience, even though since we're dealing with this all day, every day, we kind of know exactly what it is, but let's say there's people at home that know it's the HIPAA form, they know that they signed the privacy form, but what does that mean? Like it's coming from you instead of on a piece of paper where they have to read it.
As far as the logistics of the health information exchange, we have a system in place here in our city where you opt out. So you have to opt out of the system. So you're automatically going to be part of the system, and you have to ask to be opt out.
I see. Okay.
And that's just the way it was implemented.
Now
so
I'm going to stop you only because I'm a little confused there. So is this everyone who, so meaning all providers that are already yes?
well, everybody who goes to the hospital.
Everybody
so
goes to
right
any of
now,
those,
right
okay.
now, if you're admitted or if you're in a facility that has the system,
Okay.
you're automatically information will be put on unless you opt out.
Okay.
But I mean, there is no reason to opt out, and some people may ask for that, but
Right.
it's not really something that should
That
be
people
done.
at, yeah, exactly. And
But
so
it's
if
just
you're
that
going to a hospital that isn't in the system, then you're not in
You're not in the
automatically.
system,
Okay,
right.
I see.
But I think the information is very helpful to all the providers,
Mm-hmm.
and it's invaluable. And what we hope to accomplish in the future, and this may be getting ahead of ourselves, is where we can upload the information from the different physicians. Because right now, I can download information from a hospital admission, but if I want to upload my clinic note, my visit, or my test that I do in my office, that's something that we have to work on so that anybody else, like a referring physician, can actually access that information.
Okay.
And so that will help a lot of times communication, because I think one of the patient's biggest complaints a lot of times is that doctors are not talking to each other.
Right.
And so this will allow for the information to seamlessly pass from one physician to the other. If you're referring a patient, it goes to the physician you're asking to see the patient, the information you're asking for, and then it will go back, the information after the tests have been done and the visit has been finished, all that will be passed back. So it's a way of communicating that's seamless, instead of having to rely on fax machines or phone calls that may not happen
Right.
otherwise.
Exactly. And that makes perfect sense too. When the information is shared, and I'm going to skip Dr. Hendricks for a minute because I want to get this idea from Emily, how can I frame it? So is the information like it's on a web page and it's all under Emily Hartman? And if someone has the information, has the passwords, has the proper information, can they get everything that's under Emily Hartman that is pertinent to your health? Or is it, and I know there's some hospitals, and that's why I was asking that question, there's some hospitals that are not involved in this. Or is it that because this other hospital that's not involved, they can't get information to Emily Hartman, period? I'm having a hard time even, I know what I'm trying to ask, but I'm not asking
I
it right. You know what
understand.
okay.
So if you look up a patient, if you look at me, for example,
Right.
you'll see my full record of care from everywhere I've been, so long as they're a partner of the
That's
Health
my
Information Exchange.
Okay.
So you would see I just had a baby at the Hospitals of Providence Memorial, 2 babies at the Hospitals of Providence Memorial. My primary care physician is XYZ at Texas Tech. Does that make sense?
Absolutely, yes.
That I think
Okay.
answers your question.
Yeah. So it's the sharing, but it's statically there. So anything that has happened to you medically, that even if I'm on vacation now, and let's say I'm in the Czech Republic. So seriously, this is a case study. We're somewhere that's nowhere near America. I have no idea what their medical system is, but say that the primary physician here in El Paso was contacted and they wanted to get that information to the person in the emergency room in the Czech Republic. Is that something that is able to be done? And I would think that's a great thing, because my child was traveling abroad and she was in the Czech Republic and she had a little issue. I'm thinking, oh my God, because we don't know how that works around the world. And you just say people are taking vacations or just happen to be visiting people. Is this something that's able to be shared elsewhere if someone has the permission to enter the system? So it's a complicated question.
It is
I
a
know.
complicated question.
And it may not even be something that's on the radar yet. It could be something that's to come.
So the only people who have access to the data in our Health Information Exchange are our partners here in El
Okay.
Paso, and the VA and the military are obviously nationwide connections. So
Okay.
then it could be national. International, not yet. Although certainly our colleagues in Juarez, there's a lot of care that happens across the border, and maybe that's something that happens in the future. But right now it's more local.
Okay. I have problems with my mic, which is, you don't have to run away, it's okay. This is real live TV. So there's something going on with my mic and he's fixing me up, it's all good. We're good now? So going forward you were talking about nationally. So let's say now I'm in Denver visiting friends and I have a heart attack. And I've had 2 heart attacks before. I'm just saying that because we have a cardiologist here. And now I'm in whatever the hospital is there. I guess if I had a primary care doctor who was part of the exchange, could that permission then be given by my primary care doctor to have access to my previous 2 heart attacks because I'm on the table, I can't talk, and I was driving by myself. How is somebody going to have information? This is
Sure.
fascinating to me because I think this is such a good thing. I think the fix is such a good thing, which is why I'm trying to throw these scenarios
Yeah.
out there of how important this could be.
Absolutely, and it's actually a way that the HA has been used by emergency department physicians in El Paso. As somebody comes in trauma or in cardiac arrest, and the ED physicians have been able to look up their cardiac history, medications, and redirect their care in a different way off the standard pathway. So it's a real example of how it gets used regularly. There are health information exchanges across the country, and there is a very strong one in Colorado, so
Well, there you go.
good example. And we're looking at how we connect with those different health information exchanges so that when you're on vacation, you know, information can be exchanged more seamlessly back and forth if you're in an emergency situation. We're not there yet, but it is something that we're looking at really closely for the future.
Okay. Dr. Hendricks, I'd like to ask you, as the Chief Medical Officer, I guess the same question that I asked over here earlier with Dr. De La Mora, what are the questions that come to you when people have some kind of a pushback on this? And so do you deal directly with doctors individually, like independent doctors, or just in the hospital setting? Just some of the questions that are back questions so that we can see if there's a way that we can address some of those while we're here on the air.
I think some of it is that with technology, any new technology, it can be slow to adopt.
Yeah.
And, you know, certainly probably more mature doctors are a little less likely to want to try a new app or try something new or different. I think those individuals who need that information, your emergency room doctors, your hospitalists, people in the clinics, cardiologists, they need that information. And so they're going to be the ones who really want to access that information and learn the technology. It's not difficult, but
Right.
they want to do it. And we find those who really don't need as much of that information, obviously they're not going to want to go through the work of trying to do it. But we usually work through the chief of the department. We work through Dr. De La Mora. And once they find out how much information they can get, they don't have to repeat tests. They don't have to
Right.
repeat x-rays.
Exactly.
They can get up-to-date blood counts. That those things are what help you streamline their emergency room visit, and when in the clinics be able to say, oh, hi, okay, so this is what happened, this is what we need to do.
I agree with you completely. And as you were speaking, I was reading this question from the audience, and actually 3 of them. This one, I'm just going to throw out to whoever wants it. The caller says, I appreciate the convenience of this program as I was just filling out a bunch of forms this week. Not fun. But I'm concerned about my privacy and what is protecting all of my information from being accessed by just anyone. And then further going there to insurance companies, and this is a question from another question over here, insurance companies and pre-existing conditions, etc. So again, the reason I bring this question up, again, this is from the audience, but let's talk about the sharing within the people it needs to be shared, yes. But again, and I'm looking at you as I was talking about HIPAA, that is protected information still to the outside world. So trying to put some of that into play and putting minds at ease with that. And Dr. Escobar, I'm just going to throw that your way.
Well, I was using it this afternoon, and it's very specific. When you log in, you look for a patient. It asks you, are you taking care of this patient? Is this a relationship that you have established before, or you're establishing a new relationship? So you can't just be looking up people who you don't have just because you're curious,
Right.
or someone that you know that you just want to look up. So there are those, and the software itself tracks who you're looking up, and they will know.
And it tracks you.
Exactly.
You
They
know,
will
so
know,
there
they will
is
know that
there's
I'm
a
looking up
step in.
somebody famous or somebody that you're not supposed to be looking at. And so that information is available. The insurance companies have that information already. Whenever we have a claim, a medical claim because a patient's been seen, they ask for the medical records. So they know exactly what the physician has said. I mean, this is not a secret.
Right.
Similar with Medicare and the private insurers. So, I mean, the information is already out there. What this is doing is just allowing the information to pass from one group of physicians that may not have access to it, or providers, because they don't go to that facility. And I think the best analogy is the ones that are at UMC, or the ones that go to like I see patients who are VA patients, Veterans Administration patients, and I have access to those records from the VA where I didn't have it before. And so, and a lot of times they're on a lot of medicines, they have a lot of problems,
Right.
and I can access that information. And this
Right.
is just me accessing the information that is already in their VA records.
And again,
And it's because I have a relationship with that patient now.
Exactly. And I love the idea that there is accountability on both ends. And that's so important too. So if the person looking up the information, they have to own up to that. So it's like I can look it up and run away and nobody knows it was me. It's not like a mouse can sneak into the office and have that happen. So on the end of patients, I thought it was very important for them to know that if somebody accesses their information, that you're on the hook. It's like, okay, Dr. De La Mora, you looked me up. Why?
Exactly.
Well, it's because, my partner was trying to fix your heart and make sure that you didn't die on the table in 5 minutes. Oh, okay, I got it. Another question here it's almost the same question. Does the HIPAA policy relate to sharing of patient health information? So I guess we've pretty much answered that exact same question, right? VA. And I'm throwing this out to anybody who wants it. Does the VA, Veteran Affairs, share records with other doctors, and can my doctors request records from the VA? So if you're in the exchange, the answer would be yes. Correct? Is there any, yes, go
And
ahead.
this is national too. So any veterans, right, Emily? Any veteran who is seen at another VA and another place in the country, we can access those records.
Okay.
Which is extremely helpful because some patients travel and they may go to another VA and they'll be able to access from another VA or another facility if they're part of exchange that access the VA.
And I'm just thinking too about medications, because medications can be dangerous if they're mixed and you don't know if this person was given a medication and now they're off of it for 2 years or if they're still on it. And like you said, I love the idea of the grandma and her purse with all her meds in there, because I have been that person. I'm not yet a grandma, but I hope to be someday. But it's the same thing. I mean, years ago, it's like, okay, but I'm only on this medication for a short amount of time. Now I'm on this medication, and it's hard to keep all of that in track. We were talking about technology, and Dr. De La Mora, I'm going to go back to you. So in the world of technology, and let's talk about computer system. There's Windows, and every 3 or 4 years that changes. So let's either peace of mind to doctors who are looking at perhaps signing up, the technology that they need, like do they have to purchase software? Is that something that's granted? How does that work when somebody wants to sign up? And maybe Emily, you can pop in on this as well.
Yeah, I think Emily may be able to answer
Okay.
the first aspect, which is the financial aspect. In terms of the investment that they have to do with technology, it's pretty much minimal. All they need is access to the internet, because the access to the health information exchange is through an internet browser.
Okay, so it's a cloud-based
It's a
type thing?
cloud-based
Okay.
access. Of course, if they already have an electronic medical records, they can continue using that, and on the side, opening an internet browser that will allow them to access the information exchange.
Okay. One of you educate me, because I don't know how and when this came about, but from going medical society and or chief medical officer, when there was that date, whenever it was several years ago, that everybody has to be on electronic records by a certain date, when did that happen? I feel like it's been within this last decade.
Well, it was 2009.
Okay,
I mean,
thank
it
you.
was
2000,
with
so exactly a
it was
decade
with
ago. Okay.
The stimulus plan, the Obama came into office, that was passed, and it was initially there was a sort of a carrot that people got money to defray the costs of this going into electronic medical records for 4 years, and then after that there was a punishment.
Okay.
So 2010, 11, 12, 13. That's when the 4-year period of sort of to start.
Okay,
And then
so it started 2009. By 2013, it would be beneficial for everybody in medical records to be electronic. If not, there was, okay. I wasn't sure how that works. So from 2013 on, the majority, not everybody I'm assuming, but the majority of medical folks are on electronic records. I'm just trying to talk myself through it as well as the medical folks on the air. It wouldn't be that difficult to put this into place, correct? Emily, I see you nodding. So that says to me that you want to say something there. So perfect.
I was just agreeing with you. So we work with folks' electronic health records that they already
Okay.
have. There's no double entry for physicians. So we're
I
able
think
to
that's the beautiful thing.
we're just pulling what they're already entering into their electronic health record on the back end and including it in the health information exchange, so that there's no extra work for
Okay.
the physician.
And so if I'm a doctor right now listening to this, and whatever electronic medical system I have at the office, for the most part, whatever it may be, Matic Guy, that would work.
Yes,
Okay.
that should work.
Okay. So again, I'm just trying to look at all, because I've gone through all these questions here. I'm trying to look at all the reasons people would not want to do this. So why are and it's a hypothetical question, but I know you've heard answers, and Dr. Hendricks, I'm sending this to you. Why is not every hospital on this system? Putting you on the spot, we don't have to name the hospitals, but what in the world is going on there, and why aren't they?
I'll say I don't know.
Okay.
I will say I.
In the world of sense, making sense, it doesn't make sense?
It can be political. It can be they have their own ideas of what they want to do. It can be financial. It can be many different things. And I would not want to guess
I respect
why they would not want to be a part of the system. And
I may,
Yes,
may
by all means,
I think this is part of a broader issue or problem that we have nationwide, which is, we call it interoperability. Essentially means being able to connect information that means the same here than it means the same in a different system. So in Texas Tech Health Science Center, El Paso, we have 2 different systems, and those 2 systems were not designed to really connect to each other or communicate with each other.
Okay.
Across the street, we have our partners. University Medical Center has a different system.
Okay.
So nationwide, there is a big problem on trying to really being able to translate all of these different languages into one single language. And I think this is one of the main, or one of the first solutions that came out, is creating these regional information exchange systems, or health information exchange systems, which start to really solve that problem little by little, right? Translating that information, which is very vast and very complex, takes time, and it does take some effort. I think from the physician's standpoint, we should be very happy to be able to have access to these repositories of information. I'm also a physician. I had the chance to take care of patients where I wasn't sure if they had a resistant bacteria or an infection of resistant bacteria, or what antibiotics they had received. Looking back through through the information exchange, I was able to determine what antibiotic was used, and what pattern of resistance the bacteria that was growing had. This is rather complex information that I think is not very, not something that we want to do very fast. We want to do it right.
Exactly.
Right? Have the right information in the
And
right
that's
place.
beautifully said. It's about doing it right. And again, pre-existing issues, and not, I feel like that's such an insurance word, but it's not about that. It's about how your body has been able to react to different treatments in the past. Again, going back to cardiology, to me, I feel like that's such a big one. Is there a stent in there? I mean, but you'd have to go through all these tests and do an MRI and CAT. What does he have in there? Oh my gosh, well, I guess 4 years ago we had a stent put in there. But if you're able to access that, again, it's good for the patient, and I think it's good for the doctor. I don't know if this is information that you all have readily available, but compared to the rest of the country, El Paso, are we doing pretty good with information exchange? Are there certain states that are doing this more often than other states? And I'm looking at Emily, because I think maybe that's something that you talk about.
Yeah, absolutely. So like I said, there's health information exchanges across the country. Some are regional, some are state-based. I think we're doing pretty well. We've got a lot of wonderful partners here in El Paso participating, as well as the Veterans Administration and the Department of Defense, and we're really proud of those. It's huge. We're really proud of those connections.
That is the amount of people.
We're also working with Emergence Health Network, and to be able to integrate carefully and confidentially, as you know, so that only the right folks see it, but to include mental health information is no small feat. So we're very proud that we're able to work with our partners at Emergence Health Network as well to do that.
And I have to give a shout out. just the acknowledge the elephant in the room of our August 3rd, and I call it a massacre because it was, but Emergence Health Network has been on it as far as helping people out. So, and that's something too, when you're looking at tragedies that happen and something's new, but how is this person gonna react compared to somebody else? And again, that's another way in how this is gonna be coming in. I love that you talked about confidentiality and carefully sharing the information. And again, I guess the word sharing is the part that's not necessarily the right word, because you have to have official permissioned access to receive this information. And that's highly important to the people who are watching. Is there anything else, and again, I know I've asked this of two specific docs, but are there any feedbacks that you get as to why people would not be interested in participating? Other than we've already talked about, or is that? I'm just trying to get the world on this because I think it's the best thing ever. Because I'm even thinking my kids, I've got a 22-year-old and a 16-year-old. One has medical issues, the other one doesn't have any at all. But I'm thinking it would be nice if something happened to one of them and in the emergency room they were able to access all the information that has happened to this person. And boom, it's like having mom stand right there and giving the history when another person can't do that. So it baffles me a little bit. Not everybody wants to just jump on and get into this. Dr. Hendricks?
You're talking about the hospitals, or are you talking about the individuals?
Hospitals, I guess more about hospitals and medical providers. The last time we did the show, and Emily may remember, we had a lot of questions of concern from people that were calling in about the privacy of their information. And maybe this is something that has just dissipated over the number of years now since you've come on. And I don't think that was that long ago, maybe 4 years ago-ish. And so if that's the case, that everybody in the private sector, not medical individuals, but individuals that are patients, is there pushback from the patients anymore? It seemed like that was such a big thing a couple of years ago.
I think it's individualized.
Okay.
Certainly if you're paranoid about technology and you're paranoid about your data, which certainly we should be because of all the data breaches we hear about, and every day you hear, all these data breaches, so everybody's a little worried about that. And I think it's information. So the more information, the better we are able to, as in this show, being able to tell them that your data is protected, it's used by the right people, it's for your benefit. And I think that helps their fears, because that's what we have from all the information we have out there that we're bombarded with every day.
Exactly. And when HIPAA came about, how, and Dr. Escobar, I'm looking at you, how was the genesis of HIPAA rules? Did that also come with the Obama era, or was that
it preceded
that?
It was during the Bush administration. I mean, basically, there was a big push to make confidential medical information, and so and that's what the Health and Portability Act brought about, and so it's been expanded and it's been refined now with the technology that's come about, because back when it was implemented there was no technology like there is now.
There wasn't an easy way of sharing.
So they had to, there was just paper records. So you couldn't have records sent across fax machines or unsecured methods. But now we have electronic records which basically are transferred without any machines, and those are equally protected by the HIPAA laws.
Okay. And I love the way you said that. So if there's also, and does the patient have to sign off on sharing information?
Yes.
Okay.
Yes.
So maybe that's something we can talk about.
But whenever anybody goes to the hospital or a clinic, I mean, there's a lot of forms.
Exactly.
And then the HIPAA is one form, and then the HIE is another form, which is basically where you can opt out. And it explains that your information is going to be shared on this exchange unless you opt out.
Unless you opt out on that. Okay. A question here from the audience, and I'm not familiar with this, but I'm sending this to Emily. Is the All-Inclusive Senior Citizen Program, does that ring a bell with you, participating in the FIX system? So I don't know if that is a name of a senior citizen program, but it says All-Inclusive Senior Citizen Program. Does that ring a bell, or might
it doesn't, but
okay.
I mean, we'd be happy to work with any clinic or program. So I'll reach out.
Okay, I'll reach out. So you know what? Boom, it's
Thank you,
it's the
Catherine.
purple card right there. So I would love to, at this point, the questions that we can answer have all been answered. So I want to kind of stop the questions from here and just go to each one of the four of you. And at this point, just talk to me and or the audience about why this is such a good thing. And from Emily, maybe talk about it for the patients, and then Dr. Hendricks, I want you to talk about it from the medical standpoint, and then we're just going to kind of mish it up from this side. So on the patient's end, why is this a good thing?
Because your doctors have information that they need to care for you more efficiently, especially with our veterans and our military families. To be able to not have to wait in line to get your medical record from the VA and manually handle those releases to get a community provider information, it's huge. So to have that information flow seamlessly back and forth saves patients time. When they're in the hospital or in the clinic, that their physicians know more about their previous care can be extremely important.
And I like the idea too. To me, sometimes human error, it kind of lessens a little bit to the degree human error of misplacing the file, and that's a real thing. I mean, it happens in my office all the time too, and everybody's like, where's that file? How can we misplace it? So that's on the area of the patients. And Dr. Hendricks, I know I feel like I'm asking you the exact same question, but anything that you might want to add to what we've already talked about?
Well, I think from our point of view, it's a strategic move. So we're the El Paso County Health District, which is a large organization, and it encompasses a large area. With the trauma that comes in, we need that information. If we can reduce the tests, if we can get better information quicker, then that helps our surgeons, it helps the hospitalists, it helps everyone immediately take care of that patient, because they can do the right procedures or get them to surgery as necessary going forward. On the back end of that, strategically, it's a matter of getting that information out of the hospital to the provider.
Right.
And that's key. And information is key. So when grandma walks into the office and the doctor has that information and says, you were in the hospital, let's see, you had these tests, you're doing pretty good, or maybe we need to tweak your medication here a little bit, and I need to see you back in a week. So I think from a strategic point, it helps us be able to do population health and be able to help the cost of medicine.
And that, when you say strategic health and the cost of medicine, I am so on board with that, because again, there are so many medications that sometimes are prescribed on top of another medication that is similar to what you're already taking, but if for some reason that bottle didn't get put in the purse, you don't know. And so that again leads to other issues here and there. Dr. Escobar.
Well, I wish I would put it in another point of view. For example, if someone's having an MRI, and one of us had MRIs, they always ask you, do you have any metal?
Right.
And they say, and so I say, I don't know. I was seen somewhere else, and I don't know, maybe at UNC or somewhere else, and or I have a pacemaker, and the pacemakers now they're MRI compatible. And so the patient may not know whether a pacemaker is MRI compatible or not.
Good point.
And so the MRI may not get done because they'll ask the patient, do you know? And they don't know. But if we have this system in place which communicates with different facilities and different providers, you could actually inquire what kind of device this patient has. Do they have a metal clip? Do they have a spinal surgery? Something that will interfere with the MRI? You can't do the MRI. And so that will allow more smooth access to care and to get the MRI done, because we have that information.
Exactly. Nicely said. I'm going to ask you all, if you can, in your head, think about a case study, 1 or 2 or 3, that's been benefited by this. So, Dr. De La Mora, how about you?
Yeah, I think I try to think back during my training process. If we had patients that were not able to recall or remember all their medical information, we would have to go through a long series of steps, call their pharmacy, call their home health agency, maybe if they were living in a nursing home, call the family at 2 in the morning. We would have to go through a long series of steps to try to find as much information as we could. And even then, sometimes we would have to sort of give up and say, we are not going to be able to get this information, and try to treat the patient with the best tools that we have, but with the limited information that we had available. I think the health information exchange really helps us start removing that mentality and start saying, well, let's just look at there. And we could find a lot of the information that we used to call in the phone and spend hours, and now we can do it just in a fraction of that time. I can tell you again, I'm a physician, and I also use the health information exchange. I had opportunity to take care of patients that were what we call ultra-mental status. They were not able to recognize their environment. They were not able to give us information. And again, I think the health information exchange really helps and benefits those patients the most. So during those times, I would be able to look at their medications, or if they were seen at a different hospital, or if they had a provider, a primary care provider, then I knew who to contact after the patient was discharged from the hospital to make sure that that physician will follow the patient.
There's some kind of help in following up on that. Nicely said. Okay, this is the point too. So any case studies, again, we're not going to throw names out there, but are there any case studies that any of the four of you can think of where this has really been, oh my gosh, if we did not have this information, A, B, or C would have happened? So, throwing that out. Dr. Hendricks.
Well, I think our emergency room uses it quite a bit. And just the other day, a mature individual, had some issues and was seen at another hospital, taken care of, seemed to be doing well, and then the individual started bleeding and had a serious condition, came to the emergency room, and then they were able to access those records to find out what happened. What was the condition? Do we need to? Is there something else going on? Obviously, the patient was serious and couldn't give that information. So with that information, they were able to say, okay, aha, this is a reoccurrence of something that they had treated, and it's not unusual.
And you can be specific on that, because that's kind of what I'm looking for, because we don't have the name of this person. What was the bleeding,
it was
if you don't mind?
a GI bleed.
Okay.
And unfortunately, those can be very serious very quickly. So
and hard to detect unless there's a lot of tests.
then all of a sudden, the individual seemed to be stable, which is great. Went home. Next day, came back to our institution with severe bleeding again, and they were able to help utilize that to find out, well, where is this problem? So they can quickly go in with endoscopy to cauterize that bleed and then monitor them very carefully.
Okay.
So and it goes on, cardiology goes on with all areas.
Yeah, so I feel like cardiology, this is like...
Right. Well, people take a lot of blood thinners, and they don't even realize they're taking Plavix or Brilinta, they're taking Eliquis and Xarelto. They may not realize, and then you don't know how to reverse that agent because you don't know they're taking it. And there are medications to reverse the agent if you know they're taking it, and sometimes you don't know if the patient's not conscious and they're bleeding, and you can look up the information, find out, oh, they're on this medication, let's say Pradaxa, and there's a reversal agent for that. If it's Xarelto, it's a different one.
Okay.
If it's Coumadin, then it's a different one.
Exactly.
So you approach it differently depending on what, and you may not have access to that information without the exchange.
Okay. So let's talk about, I know the area of strokes, it's cardiology. So let's talk about someone who's had a stroke, and let's just say now, because you're able to find the information on the health exchange, this is not the first stroke they've had. Maybe before they've been smaller stroke, or now it's an ischemic stroke, before it was a hemorrhagic stroke, etc. So maybe even if there's not one you can think of one, something that could be beneficial that you now know that this person has had strokes in the past.
Well, one of the important things we know is that if someone has a stroke, you don't want to give them blood thinners like clot busters if they have a bleed, and if you have access to the information. And that's one of the first things you identify is whether they're having an intracranial bleed or it's just a thrombotic stroke. And so that can be determined faster if you had access to information maybe done at a different hospital where they have, a stroke evaluation with a CT scan or an MRI.
Okay.
So, every field of medicine really is benefited by this share of information. Because when you're blind, when you don't have information, you don't know how to proceed. And you may err on the wrong side because you're doing something without knowing what the precursors were.
Exactly. Now take that to, again, the world of cardiology. And I know there's different types of heart attacks.
Right.
So let's take that there. So blood thinners for heart attacks, I'd imagine
Right.
the majority of people who have a heart attack are because pre-existing, et cetera. Again, having that information, being specific to heart attacks.
Right. So, and then if you have a stent, you know what kind of stent they have. That may guide your therapy differently. If they've had, let's say they had an angiogram and a stent placed somewhere else, then you know what kind of stent it was, and you could find out. The patient may not be able to tell you what kind of stent they had.
So on that note, because there are so many cardiology patients in El Paso, and because you're here, what are the different types of stents that if they have to go to the hospital, it's like, what are you going to ask them? What kind of stent do you have? And they look at you, I don't know. What might some of those options
there's
be?
the bare metal stents and there's the drug-eluting stents. So the bare metal stents don't have a medication coating. The stent and the drug-eluting stents have a coating. And there's different size of a stents. And some people have multiple stents, sometimes there's have one. So it just, you know, there's a whole host of information that if you decide to change hospitals.
So how are you going to treat differently the guy with the stent that has the medication coming out of the stent versus
Well,
one
there's
that
different
doesn't?
devices.
Right,
I mean, if
exactly.
you have a device that's basically a device to remove clot, and you have a stent or you don't have a stent, you know, you want to know what's there before. The more information you have, you can take care of the patient better.
Okay.
And that's what it boils down to. And the
I'm
patients
trying to
may
get
not
some
have,
like nitty-gritty specifics.
the patients don't have.
You're giggling. So Dr. Delamore, you tell me, is there something that you have seen? And again, I'm trying to communicate stories to our audience so that we're talking a lot about technology and why it's good. But I think when a story is told, people will remember those stories. And that's why I'm asking for case studies. Might there be a story that you can remember that an audience can go, yeah, that's a great reason. And then maybe that audience member's mom is a doctor or grandfather is a doctor, whomever. So it kind of goes full circle when a story like that occurs.
I had a patient that we admitted to the hospital, and her sodium was very low. The sodium is a component in the blood, an electrolyte that's very important for patients to have normal function. When the sodium is very low, they become very confused at times, and it could be very dangerous. We struggle with trying to find out why was the sodium low, and we started treatment. A family member came to us and mentioned the medications. The medication, one of the medications was a medication, carbamazepine, and generally we use that medication for different things, but for seizures is one of the main areas.
Okay.
So our concern
And that's
was
really important,
right.
though.
That
My
was
goodness.
exactly.
Right, okay.
So our concern was if we stop this medication, the patient may end up having seizures.
Yeah.
And so we were wondering, what should we do? Should we stop the medication and start another one, or should we just stop it completely until this resolves? When we went to the information exchange, we found out that the carbamazepine was being used to treat a different pain, type of pain called trigeminal neuralgia. It's a
Okay.
pain that occurs in the face. And it's something that we can use other medications to treat that won't cause the low sodium. So we were really happy to see that that was the case, and we didn't expose the patient to more dangerous medications that are for seizure disorders. So we were able to treat the condition
Nicely
without
said.
exposing her.
And that's exactly what I'm looking for. Yeah, because when you hear stories like that, and it will translate into another story or to another condition that somebody on the air might have. Emily, I would love for you, if you have it memorized, I'm sure you do, the telephone number for the Paso del Norte Health Information Exchange. If you have a website, where can people go to get information? Even a questionnaire of debunking myths, etc.
Absolutely. We have a frequently asked questions form on our website
perfect.
that folks can go take a look at and learn if they'd like. And our website is fixnetwork.org, phixnetwork.org, and our phone number is 915-242-0674.
0674. So we're going to give that again out at the end of the show, which is going to be in a few minutes. But again, Fix Network, and Fix is, think of Paso del Norte, so think of phixnetwork.org. Telephone number 915-242-0674. And on that note, you said you have a frequently asked questions form on there. What are some of the questions that are on there that we can talk about right now that people might be interested in?
Sure. So privacy and security, absolutely. We covered that one. A lot of questions about how to participate. Physician practices often want to know how much it costs as well. That's probably one of the most frequently asked questions from practices. That's not on our website, but I'll tell you that
No, that's good. Yeah.
that practices of less than 5 physicians in 2019, we really want to grow our network. So it's just a $50 setup fee to participate for all of 2019. So we're really trying to grow, and our board has decided generously to cover the costs largely of bringing those folks on. So $50, you can join as a small
Excellent.
practice.
Very nice. Okay. And what else is on that website? Is there a form that they can fill out to sign up, or is that where you then get in contact with the physicians and or the medical facilities?
That's a wonderful idea, but it's just calling me. I'll come talk to you and get
That's
you signed
next.
up.
That's
Yeah.
it. We just had a baby 2 months ago. You know, it's time. Yeah, but I know you work completely. I mean, again, she just had the baby, and we were in meetings together on the first baby number 1. Question, I think this is to follow up the statement and or question from earlier. The senior citizen program Ben Vivir, that was the question, if that is part of FIX.
No, but
Okay.
we'd be happy to work with them, and I'll reach out to them. It's a
Okay.
wonderful idea.
There's that one too. Now it's a little bit more specific. Thanks for your help. I appreciate that. Again, this has been the El Paso Physician. We still have a couple of more minutes to go to, but we've answered all the questions that I can think of. I love the idea that the VA and the Department of Defense is involved in this, which to me also means that anyone that is serving overseas, and I know that we're talking internationally, but at least that information is served or exchanged overseas if there is a hospital that treats, and I'm just thinking about the hospital in Germany that people just fly into, that exchange goes to those hospitals as well. Is that correct? If it's part of the VA or part of the Department of Defense?
I believe any Department of Defense facility, we would get that
Okay.
information. And actually, it's been so beneficial for folks here locally, even more so than I anticipated. We had a family move here from the East Coast to El Paso, and they had a child who needed a pediatric specialist. They established care here. The physician thought they'd have to repeat all of this child's labs. My son just got his vaccines the other day. Sticking kids is not fun.
Right.
Parents were distraught. They did not want to repeat those labs. I happened to train the doctor that day on how to use the HIE. I helped them pull up the record from that child from the East Coast. She didn't have to repeat any labs or imaging studies and was able to continue
Fantastic.
care more seamlessly. So that national component is really important for our
It's
community.
priceless in a situation like that. Again, thank you so much for joining us. We've had Dr. De La Mora, Dr. Escobar, Dr. Hendricks, and then Emily Hartman on with us this evening. And again, it's talking about improving patient care through data sharing. And you can watch this program again on kcustv.org. Go to Watch and Local Programs. You can also watch this program again on El Paso County Medical Society website, epcms.com. I'm Catherine Berg. Good night.